Good evening, everyone. I'm sorry about that. I had some technical difficulties. I see that there are plenty of you on who got to see my technical difficulties, but let's get started. So I'd like to welcome to our second virtual panel discussion, and it's centered around our coronavirus pandemic. My name is Michelle Sally. Some of you know me, and I am the public health program coordinator and a faculty member here at the Department of Public Health and Health Sciences at the University of Michigan, Flint. I'm really excited about today's presenters, and I thank them so much for being with us tonight. Just a few housekeeping items before we begin. We'll have two screens showing at all times. In one of the screens will be either Mitch or Corey. Corey is with us now, who will be our ASL interpreters for the event. On the other screen will be the speaker or the slides from the speaker. So forgive me in advance. I know I had some technical difficulties already, but this is the first time we've done the Zoom, and it's the first time we've used the ASL interpreters, and we're really happy to do so. But I'll try to do smooth transitions between everything, and just bear with us if I don't. We will have two question and answer sessions, one after our first two speakers and one after the next three. I'm going to ask everybody to please type your questions or comments into the question and answer box, and note what speaker you'd like to direct the question or comment to. And I'll moderate that question and answer session along with one of the ASL interpreters. So I'll try to get to everybody's questions as best I can. Okay, so without further ado, today's theme is vulnerable populations and the coronavirus pandemic and what can be done to help. This theme was chosen based on feedback from our last panel, and we have some really great presentations tonight, so let's get started. Our first presenter is Dr. Lisa Laparose. Dr. Laparose is an associate professor in the Department of Public Health, and I should know, I worked at Public Health and Health Sciences. I'm going to put her on the screen now. So just bear with me while I figure this out. There we go. Dr. Laparose, are you with us? Okay. Dr. Laparose is, like I said, is an assistant professor in the Department of Public Health and Health Sciences here at the University of Michigan, Flint. She holds degrees in Women's Studies, Mexican American Studies, Health Behavior, and Health Education. Dr. Laparose also has over a decade of research experience. She's done scholarly presentations, and she has publications dedicated to addressing health problems and populations more broadly. Dr. Laparose has received several prestigious teaching awards, highlighting her commitment to training future public health leaders. Locally, Dr. Laparose is an active member of the Latinos United for Flint. So Dr. Laparose, I'm going to let you take it from there. Ma'am, are you on mute? You're on mute.
All right, so let's go ahead and share. Okay, the title of my talk is Race, Racism, and COVID-19, Disease Vulnerability Among Communities of Color. The fact that African American, Latinx, and Native American populations have disproportionately contracted and died from COVID-19 has garnered national attention. A logical question to ask is, why is this happening? In general, there are two major perspectives on this issue: a genetic, biological explanation and a social determinants explanation. To illustrate these these conflicting arguments, we can look at public statements made by different government officials. So here you see a picture of William Bill Cassidy, who is a physician and senator for Louisiana. When NPR asked about the disproportionately greater rates of COVID cases and deaths among African Americans in Louisiana, he focused his answer on the ACE receptor, citing that there was a physiologic reason why African Americans were disproportionately impacted. To better understand this biological explanation, let's take a closer look at the role and function of ACE receptors. ACE stands for angiotensin converting enzyme, which is a central component of the renin-angiotensin system, or RAS, which controls blood pressure. ACE2 is a protein found among the surface of certain cells in the body, including the lung, heart, kidney, gut, and most recently, cells in people's noses. ACE2 is a receptor that has been identified as the pathway in which the SARS-CoV-2, which is responsible for COVID-19, also known as coronavirus, enters into the cell. People with diabetes tend to have higher levels of ACE2 receptors. In addition, animal models suggest that hypertension medications can increase the concentration of ACE2 on the surface cell, increasing the number of entry points for the virus. Based on this knowledge, it has caused some to speculate that those who take blood pressure medication, and thus those who disproportionately suffer from blood pressure issues, such as African Americans, are at increased risk for coronavirus. Yet, we don't know if this is actually the case, since we lack data from human studies. So please, 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 please continue to take your blood pressure medication. We only know about rats. A discussion of ACE2 receptors provides some insight towards understanding why populations with high rates of diabetes and hypertension, namely communities of color, face disproportionately greater risk for COVID-19. Yet this explanation fails to address the root cause of these health inequities. When asked why Louisiana's African Americans were at increased risk for contracting and dying from coronavirus, Congressman Cedric Richmond of Louisiana's 2nd Congressional District said that these health inequities are rooted in years of systemic racism. But Senator Bill Cassidy said that that is simply rhetoric, and that he was basing his perspective on science, which begs the question, who is right? Is the root cause race or racism? To more fully explore this question, it's important to understand the social construction of race. While race is often perceived to be a biological category, race is a construct that is socially imposed and hierarchical. From various studies of genetics, we know that 1, no racial group possesses a completely separate and distinct genetic composition. 2, there is greater genetic variation within racial groups than between them. We see this clearly in Latinx families where siblings from the same parents have very different skin colors, hair textures, and facial features. Indeed, 3, the genes responsible for physical features, which have been used to categorize racial groups, are few, atypical, for physical features such as skin color, are few, atypical, and not associated with genes responsible for disease. And finally, 4, according to Leonidas and colleagues, I apologize if I mispronounced the last name there, who studied 43 validated gene disease associations across 697 study populations, found that while genetic markers for proposed gene disease association vary in frequency across populations, their biological impact on the risk for common diseases is consistent across traditional racial boundaries, thus leading to the conclusion that race is more useful for social rather than biological explanations for group differences in disease prevalence. Although several decades worth of research have challenged the legitimacy of race as a category for human genetic diversity, these explanations for disease prevalence continue to persist. Countless numbers of researchers have dedicated their careers to the study of racism's impact on health. Dr. Sherman James, Professor Emeritus in the Stanford School of Public Policy at Duke University, is responsible for developing John Henryism, which is the study of how persistent, high-effort coping in the face of social and economic adversity contributes to disparities in hypertension among African Americans. Likewise, the esteemed Dr. David Williams, Professor of Public Health in African and African American Studies at Harvard University, has spent his career investigating the impact on racism on both physical and mental health outcomes, including cardiovascular disease and hypertension. Dr. Williams even has a TED Talk devoted to a discussion on how racism makes us sick, which I highly recommend. I just wanted to point it out that I had the very distinct pleasure of learning from both of them when they were employed at the University of Michigan, so go Blue. These researchers, along with numerous others, including myself, researched the physical and mental health toll racial and economic adversity have on the health of communities of color. In this body of work, we can see how things like chronic stress, stemming from racialized economic disadvantage, as well as race-based traumatic stress, result in wear and tear on one's body, leading not only to diminished physical and mental health, but premature death as well. This study of what we call social determinants of health, while rejecting race as a genetic category, does not deny the fact that there are pattern physiological responses and, by extension, health outcomes that are common to communities of color. Rather, it argues that these patterns of health are the embodiment of racial injustice. Despite an immense amount of compelling research on the relationship between social determinants of health and health inequities experienced by communities of color, race as a genetic explanation for disease vulnerability continues to persist. Part of the reason why we continue to encounter these arguments is due to the way healthcare professionals are trained. Physicians and other healthcare professionals may receive little to no exposure to research on the role social determinants play in health and health outcomes. In addition, systemic racism simply feels too big of a problem to tackle. Our inclination and training lead us to focus on what we believe we can fix now, which is health behavior and a focus on personal responsibility. So I've included this picture here of the US Surgeon General, who was criticized for making comments to Black and Latinx communities saying that they should step up to avoid alcohol, tobacco, and drugs, failing to recognize the context in which those behaviors occur. Now, while it's important to acknowledge that we as individuals are active agents in shaping our own health, we do a grave injustice by having these conversations without equally stressing the context in which these behaviors occur, where access to health promoting and protective resources are limited at best. Finally, acknowledging that systemic racism exists and is the root cause of health inequities experienced by communities of color, challenge our collective beliefs about justice. We can all point to someone, perhaps it is ourselves, who has beaten the odds, but these are the exception. Systemic racism is real. We only need to look at places like Flint or Mexican Town in Detroit to see how it operates through things like redlining and residential segregation. Mexican Town is one of the most polluted places in Michigan. It is surrounded by 3 major highways, a wastewater treatment plant, a steel mill, coal and gas-fired power plants, and a 6-lane bridge is currently under construction. We cannot pretend that the placement of these facilities are a coincidence or continue to ignore the fact that your zip code is a significant predictor of one's life expectancy. Dismantling systematic racism is no easy feat. Yes, yet we must commit ourselves to ending it. In the words of, I'm gonna probably mispronounce this, let's just say Dr. G, senior lecturer in the Department of Global Health and Social Medicine at Harvard's Medical School's Center for Bioethics. Dismantling these systems will require that, 1, white people sit with the uncomfortable reality that they have benefited from a racial hierarchy that has harmed others. 2, that the intent of policymakers and health policy itself is less important than their effects. And 3, those affected by systemic racism have crucial knowledge about effective strategies to reduce and end it. Thus, representatives from vulnerable communities must be present at decision-making tables. They need to be fairly compensated for their contributions and given an appropriate decision-making power to have an impact. This is just a link to ways that you can take action and some of my selected references. Thank you.
Well, thank you very much, Dr. Lapierrose. We're going to switch our interpreter now. So I have to make sure I can do that right. So Mitch should be joining us. Hi, Mitch. And we'll see you later, Corey. Thank you very much, Dr. Lapierrose. So our next guest will be Representative Dan Kildee, and he will be with us in a second. Let me put him on. Okay. Have to find him. Dan Kildee. So. Okay, it just takes a second for the computer to do what it's supposed to do. There he is. There he is. Great. So we are going to resize this. I have to figure out how to do this. I don't know why. I apologize for my technical difficulties. There we go. Now we see both of you, right? Okay, so Representative Kildee was born and raised right here in Flint and is a lifelong Michigander. In Congress, he brings people together and gets results for his constituents in Michigan. Congressman Kildee holds various leadership positions in Congress, including Chief Deputy Whip and as a member of the Ways and Means Committee. Representative Kildee co-founded and served as the president of the Center for Community Progress and founded the Genesee County Land Bank. He also served as the Genesee County Treasurer and on the Genesee County Board of Commissioners and on the Flint Board of Education. Representative Kildee also worked for 8 years at the Whaley Children's Center, which is right up here near the university, and he lives now in Flint Township with his wife, Jennifer, with whom he has 2 children and 2 grandchildren, Caitlin and Colin. So without further ado, I know we came here to listen to the presenters. So Representative Kildee, welcome.
Thank you very much. Thanks for inviting me to be a part of this. It's a really important discussion and it comes at a pretty important time. Michigan ranks 3rd among the states for most COVID-19 deaths. Genesee County itself has the 4th highest number of cases in Michigan. And we have data that's really clear that points out the disparity that this session is intended to go deep into. In Michigan, 14% of the population is African American. 32% of the confirmed COVID-19 cases are African American, and 41% of the fatalities. So 14% of the population in Michigan represent 41% of the fatal cases and 32% of the COVID-19 confirmed cases. So just that piece of data alone is pretty instructive. We wouldn't have that information were it not for the fact that the Michigan Department of Public Health is tracking and analyzing these data, which is something that we can't say is taking place at the federal level. I have joined with 90 other members of Congress in introducing legislation that would require the collection and disclosure of data, demographic data on COVID-19, excuse me, in order to inform us. I mean, as was demonstrated by our previous presenter, the data has to inform these decisions. The data and the science have to inform the conclusions that we come to about these disparities that we see. So it's important that the federal government collect that information the way the state of Michigan is, and we are pushing it. It's important because we do see in Michigan's data, but also anecdotally, tremendous disparity across not only the racial spectrum, but economic, other aspects of society when it comes to the impact of COVID-19 or many other less well-known health issues. I mean, right in Flint, we are dealing with one health crisis, which the entire planet is dealing with, on top of another health crisis, the Flint water crisis, which by itself is another example of the disparate impact of societal institutions on communities of color. And it's impossible to avoid the fact that if you look at sort of the 2 cases, COVID-19 and the Flint water crisis, clearly different sources, clearly different drivers, clearly different origins. But in both cases, in Flint with the water crisis, I have always been of the belief that, number one, the crisis never would have occurred in a majority community. And if it had, they'd have run out of blue ribbons for the state and national commissions that would have been appointed to deal with addressing this problem. But the fact is, it was a poorer, majority minority community, and it was essentially expected that that community would go through a crisis like this. So to me, it's hard to avoid the two, but it's really important to get good data. And you know, the point that the previous speaker made, I know Senator Cassidy and I know Congressman Richmond, and Congressman Richmond is right. This is a case where these long-term systemic disparities have had a health implication, and the current crisis is just another example of it. The difference, of course, between long-term continuous health disparities over time is that those health disparities manifest in data one day, one person at a time. What we have now is data that's all happening in real time in the space of just a few weeks. And so it's really important to keep in mind that what we're seeing now with COVID-19 happens in slow motion among communities of color every single year. It's just happening all at once because of the nature of this pandemic. But the impacts go further than that. In communities of color, which very often are areas where we have concentrated poverty, we need policy that is driven by data. We can't, for example, we tell people to wash their hands to protect themselves. You can't wash your hands if your water is shut off or if the water is not clean. We tell people that we're going to make testing available in communities like Flint or Saginaw, and it's going to be drive-through testing. If you don't have transportation, how do you get to the drive-through test? We're told to stay at home and to shelter at home and to work from home if you can. But if you don't have an extra room in your home, if your living conditions are such that that makes it very difficult, the idea of being able to shelter at home is just a wish. We're asking people if they're sick to call their doctor. Well, you have to have a medical home in order to do that. You have to have access to healthcare. Disproportionately, people who live in poverty and disproportionately communities of color are less likely to have a medical home and be connected to the healthcare system. So these are the kinds of disparities that underlie the problem that we're seeing and the data that we're seeing right now. And I was going to give a longer presentation, but I really do think it makes more sense to reserve as much time as possible for questions. But I want to make one additional and I think very important point. Many of us, I have been working with Dr. Fauci, who is obviously one of our national leaders and is walking a very tight line right now, trying to stay in a position of authority, but continuing to push for better, more science-based decisions to be made at the federal level. But Dr. Fauci addressed this issue of racial disparity in COVID-19. I think it's really important to think through the entirety of his answer, because when pressed, he was addressing these long-term health disparities that are very much rooted in discrimination, societal biases, the obvious connection between poverty and race. And what he was asked was, well, what can we do about that? And he said, well, we can't do anything about that right now. And many took that to believe that there wasn't anything that we could do in the period of the COVID-19 pandemic to address those disparities. What he was referencing is that in the space of a few weeks, we can't undo decades and decades and truly centuries of disparity in access to the essentials in healthcare in the space of just a few weeks. But what he did not say, and he made clear later on, is that that does not mean and should not lead anyone to come to the conclusion that there is nothing we can do to deal with the disparities when it comes to COVID-19 on issues of race. Just because we can't deal with the long-term systemic drivers of these disparate impacts does not mean that the interventions that we can deploy wouldn't have a positive effect, and they would. I'll just give you one example. Congress has passed a whole series of pieces of legislation, much of which is intended to give people the economic tools in order to shelter at home. You can't shelter at home if you're worried about feeding your family. People living in poverty don't have a bank account to go to get them through 2 months or 3 months of unemployment. So one of the things we have to do is make sure that we have resources available. But one of the other aspects of the help that we provided was to support hospitals, which are under tremendous stress. Just one example of the disparity that is built into the system is that the instinct of the federal government was to develop a formula for supporting hospitals that disproportionately supported hospitals that depend more on Medicare than on Medicaid. What is the effect of that? It is to spend more money in the places with the least amount of poverty and less money in the places with greater amounts of poverty, more people who are disconnected, more people who are left out of the healthcare system. And because of the racial components of poverty in a place like Flint or in Saginaw, what that means is less help for the institutions that help those people. So let me leave it at that. I think this is a good conversation, but it's one that absolutely has to rely on good data in order to drive the discussion and policy choices driven by that data. So thank you. I'll turn it back.
So thank you, Representative Kildee. I gotta say, data, that's my thing. So go data, go data. Please stay on. We're going to change interpreters, but I think we have some questions for Congressman Kildee. So I am going to just, Mitch, take a break. See you later, Mitch. And Corey is back with us. So I do have a couple questions from the audience for you, Representative Kildee, and I'll read them. Unfortunately, they don't always have their name on them, but this one is Dawda Abubakar, one of the professors here, and his question was, the state of Michigan has been one of the most seriously affected states with COVID-19 fatalities. What would Congress do to address the budgetary challenges of Michigan and local communities?
It's a really good question, and there's a real debate happening right now in Washington on this very issue. It is our belief that the relief that we need to provide goes to families, to small businesses especially, to hospitals and healthcare providers, and to state and local governments, because state and local governments are seeing two things happen simultaneously: significantly increased demand for services in treating and dealing with COVID-19, and at the same time, because of the way we've shut the economy down, deep losses in tax revenues, particularly coming from sales tax and income tax. And because those choices are being made logically, it's my belief that as Congress moves forward, we need to spend significant financial resources to backfill the losses that those state governments and local governments are experiencing. But unfortunately, while the majority of the House of Representatives believes that, at least in the case of the Senate Majority Leader, who happens to be of the opposite party, he did an interview on a radio program hosted by a guy named Hugh Hewitt not too long ago, wherein he said that the solution may be for those states to go bankrupt, which I think demonstrated a couple of things. One, an ignorance of what that actually means. And secondly, a sort of callousness to what a bankrupt state actually means for the people who live there. This is a crisis that nobody chose. This is the fact that Michigan is at the center of this is not of our choosing. It wasn't a result of bad choices that were made. It's a result of a virus. And so I think we're going to have some hills to climb in order to get the Senate to agree with us that we need to support state governments, and we need as many voices as we can. I know our two senators support it, but for those of you who have relationships elsewhere, it might be a good time to speak up and demand that the Senate do its job and support state and local governments get through this.
Thank you, Representative Kildee. We do have two more questions for you. The first one is, what kind of more detailed data will you collect through the proposed legislation? And how would you use that data in to develop interventions?
It's a good question. The data that we would like to see would fill in the blanks in terms of some assumptions that are being made by anecdote. For example, through various anecdotes and largely data coming from other countries, there has been a lot of conclusion drawn and speculation about the impact on individuals based on age or other conditions. Certainly the issue of race. We need to know the racial disparities. We need to know the populations that are at greatest risk in order to properly deploy the resources to prevent those populations from having that risk realized. So the collection of data would be done in a manner that would not just be for our own academic consumption or interest, but it would not only inform our current conditions, but decisions, but inform later decisions about how we deploy preventive resources to try to minimize the effect of something like this, even if it were more contained on specific populations. The only way to know how to target the resources is to know where we have people in greatest risk. And if it is, as we now know the data shows, determine that communities of color are at much greater risk given the relatively equal levels of exposure, then we should be targeting more financial resources, more health resources into those communities. So that's really the purpose of collecting that data.
Well, thank you very much. Hopefully I'll get this recording and I'll show it in my epidemiology class because that's part of what I teach. We do have one more question. Actually, now there's two. The next question is, will there be more programs put in place for maternity populations affected by COVID-19? WIC offices are closed on a county by county basis, making it difficult for these women to obtain essentials in these hard-hit areas.
Yes, and I'd like to follow up and get more detail, but we did increase across the spectrum support, nutrition support, which would include WIC. What we're trying to do is find those communities that are at greatest risk for, in any category, and make sure whatever resource was intended to help them through their issue. If in the case of the WIC program, nutritional support, we did include in the CARES 1 Act a substantial increase in food and nutrition programs, but I'd like to follow up and get more detail on specific, other specific programs that might be directly supportive of that particular population. I don't have that right in front of me.
Okay, thank you. Actually, our next question is for Dr. L, so I'm just gonna put you on mute for a second and bring her up so that we don't make the interpreter too small. Dr. L, I have two questions for you. One is, I know you focus some of your research on people living by the border. What are the COVID-19 risks there, and what interventions do you recommend? You're on mute.
Okay. I think a lot of the risks are similar for Latinx communities, regardless of where they're located. And so in addition to, working in fields that may be considered essential, so some factory work and stuff that increases their exposure, I think what we're seeing is, there are some places, some communities, such as the Latinx community in Flint, where ways to distribute information are lacking. And we saw this very clearly with the water crisis. So there's no Spanish language radio that's locally broadcast. There's no Spanish language TV. And so you have very limited options in terms of how to get information out and protect oneself. So I think other communities, like a border community in El Paso, where I did my research, or in Los Angeles, they have a lot more infrastructure to assist. But we have to think about places such as Flint that don't necessarily have that. Let me
So, your next question was to you, Dr. Al, what kinds of resources are being offered to immigrants in our community? And I think you've addressed that for the most part. I do have another question that's addressed to both you and Representative Kildee. So I'm going to leave you on, and let's unmute Representative Kildee, and whichever one of you wants to answer, I'll put onto the screen. But this is for both presenters.
Wanted to make a comment about
sorry.
resources. So even when resources are available, there is research that has documented that fear of encountering deportation, so ICE, regardless of your citizenship status, is deterring people from seeking help. And we've seen this before COVID-19. And so that means that even if you are a citizen, fear of harassment or potential repercussions for friends and family members will keep people from accessing resources. So when we think about interventions, it's really key to have partnerships with trusted community partners that can help us do this work, because people are not going to leave their homes and not access things that may be available to them for fear of, potential problems.
Okay, sorry I had interrupted. So we have one more, and I know Representative Kildee needs to go to another engagement pretty soon, so I'll try to read it quickly. So I think this is for both of the presenters. I think both of you attempted to address concerns related to COVID-19 and minority populations, but what are your recommendations for solutions that directly impact minority populations? And this is just a comment in the same question. Just putting money in the community will not do it. Thank you, Dale Sanders. So would you like, which one of you would like to address that? Okay, I will. Representative Kildee, are you still there? I don't know if he's still there.
I can say that one of the things that
I can't get him. I'm sorry.
we have advocated in our research is providing a livable wage. Raising the minimum wage is one step that we can take, so that people are not having to work multiple jobs to make ends meet, and making sure that they have access to not just healthcare, but quality care. I think those are two big legislative steps that we can take.
Thank you. Thank you, Dr. Al. And Representative Kildee, would you like to answer that?
Yeah, I think the point is correct. First of all, in the emergency that we're in right now, we have to get financial resources into the hands of people who were asking to shelter in place. But I do think there's an interesting lesson from the current crisis that should inform our policies more broadly, because it is our national instinct in this moment to get money into the hands of people who are at risk, to make sure they have the financial resources to protect themselves and protect their families. It's in our national instinct, and we're seeing Congress act to do this, to make sure that access to healthcare is supported. Now, we've got a big hill to climb in terms of a delivery system that is not built to provide healthcare for everyone. But when you look at the literally trillions of dollars that are being spent in the space of about 6 weeks to provide for financial support for families and healthcare for families, it sort of begs the question as to whether or not we ought to have an economic system that puts every American family in a position where they're not one miscalculation away from losing everything they have, where they do have the financial resources to get through a financial emergency. where they do have a medical home to turn to when they face their own private epidemic, their own private COVID-19. It doesn't happen on the headlines of every day, but happens to them each and every day in 1,000 different ways in hundreds of different places. We have to have a stronger minimum wage. We have to have stronger Social Security. We have to have universal health care. These are policy choices that we make that make all the difference in the world.
So I know you have to go to another engagement, Representative Kildee. We do have one question. I don't know if you have time for it. If
Sure.
not, okay, then I'll ask you it. What do you think about the Safe Start plan by the governor, which grouped counties together for a startup plan? I'm concerned, not me, but the person who wrote it is concerned because Lapeer and St. Clair County are grouped with Detroit Metro. And even though the numbers are much less in Lapeer and St. Clair, I would think the opening of these counties would look much different.
I think the opening of different communities and different industries are going to look different. And I really am not in a position to offer an opinion on that detail. That's a state decision. I do have my views that we have to be very cautious. And if we're going to err on the side of making sure we provide support and open slowly, I would rather do that than see us open up too quickly, make a mistake, and see the second spike of COVID-19 being worse than the first.
Okay. So I know you have to go. Thank you so much for coming out and
My pleasure.
playing with us. Sorry about the technical difficulties, but we hope to see you again. So that's the first time
Absolutely.
here on campus, and it's always a pleasure. Thank you so much.
Thank you very much.
You're welcome. We will be changing now our ASL interpreter. So if you just give me 1 second, we'll do that, and then we'll go on to our next presenter. Okay, Corey, we'll see you later. Okay, and maybe I'll go on now. So that was great. I know there's another question in the question box, and it is for Dr. Lapierrose, but I'm going to leave that for the question and answer at the end so that we stay on schedule here, if you don't mind. Our next speaker, who is actually my boss, is Dr. Shan Parker, and she holds expertise in health behavior and health promotion. She's focused her efforts on working with vulnerable communities, especially African Americans, in addressing the impact of health disparities on disease prevention. Her work has led to developing culturally relevant interventions for minority populations, and her credentials include an MPH in epidemiology, gay epidemiology, and over 25 years experience in public health. Dr. Parker utilizes community participatory research practices to address health and health equity in Flint and Genesee County. So with that, I'm going to turn myself off and I'll welcome Dr. Shan Parker. Welcome, Dr. Parker.
Thank you, Dr. Sally. I agree with a lot of what Congressman Kildee had to say and Dr. Lapierrose earlier. And in light of the time, I'm going to really just jump into some of the factors that are impacting why coronavirus or COVID-19 is devastating African American populations. So when you think about some of the things that have already been said, many of the reasons why we're seeing such devastation in African American populations really gets back to this whole idea of inequities, right? Healthcare inequities. So we have to have a larger conversation about those social structures that impact poor health outcomes in general and those specific to COVID-19. So I want to talk about a couple of topics or a couple of factors that are disproportionately, that help us to understand this disproportionate representation. So the first thing that we've been talking about, or that we've heard about, is this whole idea of pre-existing health conditions, right? So what we already know is that people who contracted COVID-19 were at a much higher risk of having severe illness and death if they had certain pre-existing conditions: type 2 diabetes, hypertension, asthma, kidney disease, heart disease, those types of health issues. So in thinking about that impact of COVID-19 on those populations, or those people, their bodies were already in a compromised state, right? So they were already trying to get to this level of optimal functioning. So with this very unforgiving virus, that limits their capacity even more in being able to get to that optimal level of functioning. So now what I really want you to understand is that while we talk about these pre-existing conditions, and sure, there is personal responsibility on everyone's part, but there are some structural inequities that are in place that impact why people have these pre-existing health conditions. So really, when we talk about this, I'm talking about social determinants of health, right? I am talking about health disparities. I am talking about why there is this gap between people who have better health outcomes and these people who are having worse health outcomes, and what's happening in the middle that really gets to why African Americans are disproportionately affected and have disproportionate poor health outcomes. So, so I want to talk about that. So when I say social determinants of health, I'm talking about poverty. I'm talking about food insecurity. I'm talking about access to healthcare, education, all of those things that impact, or those social structures that impact your health, that impact your life, right? So when we talk about things like the physical environment, all of those things are factors that impact your health and those health outcomes. So let me just bring it around for you. So place matters. Your zip code impacts your health. It impacts your health access. So when you're talking about living in a food desert, if I'm a person who has diabetes, I have hypertension, well, that limits my access to fresh fruits and vegetables. It even limits my access sometimes to the quality of food that's offered in my grocery store. So what you have to know is, in order for me to even be able to address and deal with my pre-existing conditions, there are these structures that are in place that provide barriers for me. Right? So then when you talk about this whole idea of your physical environment, so we always promote getting in your physical activity. But if I don't have access to green spaces or parks where I am able to ride my bike on a bike trail, or to do these walks, or to get this physical activity, those are also barriers that exacerbate my pre-existing condition. So again, all of those things are those structural inequities that impact those comorbidities, right? So now, when you even think about people who are asthmatic, if your neighborhood, and we know with redlining that neighborhoods have been set up in ways that when you are poor, then you don't have the access to the best places, or you're in those places where, you know, you have more exposures to toxins. So if you're talking about lead in your house, and you're talking about being close to a factory or something where there's some pollution, and I'm an asthmatic, that exacerbates my pre-existing condition. So now you bring it all the way back around to COVID-19. So I have these pre-existing conditions, and because of all of those structural inequities, then I'm more at risk of having these poor health outcomes. So a second factor that I want to talk about is that African Americans are have a disproportionate risk in terms of having increased exposure to spaces and places. So what I mean by that, people have been told to stay home and stay safe. Well, that is great, and we absolutely should do so, okay? But however, there are people, and I think Congressman Kildee kind of referred to this, don't have the luxury of having jobs that allow them to work remotely. So now when you think about that, bringing it around to COVID, African Americans going to make up a large percentage of the population who either cannot afford to stay home or they are working in those sectors that include being essential workers. So those are the lower wage earning jobs, right? So we know based on the Bureau of Labor Statistics that most minority groups are overrepresented in those jobs, right? So those are the restaurant workers. Those are, your security personnel, grocery store workers. So people who are having to go out because they're essential workers. Now, what does that mean as it relates to COVID? When you are continuously having to expose yourself to the outside, or outside your home, then you are more likely to become infected while you're at work or even while you're commuting to and from work, because a lot of folks are having to use public transportation. So the more you're out, in terms of increasing your risk or exposure in those spaces and places, that increases your risk. Now, that leads me to my next point when it comes to this whole idea of social distancing. So African Americans are leaving their homes more frequently. So while doing that, that puts their families at a greater risk of contracting COVID from them. So now we're talking about families that live in intergenerational homes, right? So when you're an essential worker and you're coming home and you have your elderly parents, you might have your elderly grandparents or elderly aunt or cousins or sisters or whoever that might be, you're not able to social distance yourself from your family members. Even if you don't have symptoms, you're still in those spaces and spaces that are confined, and you're putting your family members at an increased risk. Well, if I'm asymptomatic, but I have family members who have these comorbidities or these existing conditions, I've put them at an increased risk. So the whole idea of being able to social distance yourself is likely not possible to do so. So I want to talk about another fact. When you talk about the whole concept of testing, the way we set ourselves up to do testing in this community around COVID-19 also impacted this disease for African Americans. So if you recall, up until recently, you could only be tested if you were a healthcare worker, if you were having symptoms and you had a primary care provider that provided you with a referral or a prescription. Well, when you think about African American populations, most people are unlikely to have a primary healthcare provider. They may not even have insurance or are underinsured, so they don't even go to the doctor. And for those who are going to the doctor, there are all these other issues that might present. I don't have the healthcare provider. I don't trust my provider. We don't communicate very well. So I'm less likely to get that referral to get tested. So that by itself, having the healthcare provider is a barrier to testing. So now we know, coming right back around, we know now though, that everybody has access to testing now. But even with that, and even having some access to testing, there are some other issues that are gonna come up with that, but I'll leave those for a little later. So I wanna just confirm that. So not having a primary healthcare provider posed a real issue for people getting tested. People were denied getting tested because of for whatever reasons. So people didn't get into the system early enough. And as a result of that, we had these poor health outcomes or poor health results related to COVID-19. So I want to talk about, because Dr. Sally is telling me I have to finish it up. So there is one other factor I want to talk about. So there was this myth among African Americans where they believed that we were not, so African Americans were not at risk of developing, or we were immune to getting COVID-19. We know that is absolutely not the case. But when you think about what we were seeing and what was getting communicated in the media, I can understand how people got that misperception, right? So we were talking about people having COVID-19 who were traveling abroad. They were going to China. They were going on cruises. All of these things, or all of these actions perpetuated among, right or wrong, perpetuated among African-American populations that we were immune to this virus. And that was not the case. And as a result of that, some people did not put social distancing in place. Some people did not take the issue seriously enough. But I can understand how that myth began to circulate among the population. So I want to say one last thing because I have to finish this up. Now, as we're moving toward our new normal, and I just want you to think about this, and we're asking people to wear masks. We're asking people to wear bandanas around their faces and cover. We have to think about that from an African-American perspective, right? So we're talking about a population of people who are often racially profiled. And now when you're talking about having to wear personal protective equipment, while that mask should signal some level of health precaution, in some people, it is going to signal potential criminal behavior. So even as we are putting things in place to try to impact and reduce our risk of acquiring this infection, we have to think about what we're seeing and what we're doing. So with that, I'm going to stop and just say this. We have had health disparities and health inequities for a very long time. This is not a new conversation for us in public health. In fact, I think probably any of our students in public health and health sciences could have probably talked about this just as easily as I did. But the structural inequities that have existed before COVID-19, before the Flint water crisis, have not yet been changed, right? And until we start to do something, right, to address these health disparities and start looking at health equity, we're going to continue to see ourselves in these situations. So with that, I'll end.
Thank you very much, Dr. Parker. I do have several questions, but we'll go over them at the Q&A at the end. Okay, thank you. We're going to be switching interpreters now. So let me get Corey back here. And we'll say goodbye to Mitch. Hi, Mitch. Okay. And Dr. Parker will talk to you soon.
Okay.
Oh, I am going to stop your video. And so our next speaker, I am going to put our next speaker up, is Teresa Miracle. And let me get to her to put her on. Teresa. And I'm so happy that she was able to join us today. Let's wait for her to come up. There she is. And maybe we need to switch now. And Corey, you need to talk. Okay. And so you're not on mute, right, Corey?
Nope.
Okay, so Teresa Miracle she has a Master's of Arts and she's the Executive Director of the Communication Access Center for the Deaf and Hard of Hearing here in Flint, Michigan. Teresa is a deaf person who advocates for the deaf, hard of hearing, and deafblind communities. So welcome, Teresa. I'm so happy you could make it here today.
Hi, thank you so much. I'm thrilled to be here. And I've heard a lot of different things. We have a lot of people of color. We have a lot of oppression, just as deaf folks have also experienced oppression. So we have the same frustrations, the same barriers, we just account it in different ways. We, unfortunately, are all constantly fighting for language access. A lot of our deaf children are language deprived because many parents don't know sign language or don't learn it until later in their lives. And it's a constant struggle. And now with the coronavirus impacting everyone, at first the deaf people didn't even know what coronavirus was. The community we had to try to show a picture because unfortunately, or the community themselves, the deaf community is a visual community. We rely obviously on visual cues and signing. And so when the coronavirus came out, we came up with this sign for coronavirus, and it depicts the shape of the virus and how it spreads. And when it first came out, the deaf community was chattering and they really didn't understand it completely. And then We've seen a bunch of information coming across social media. There was a lot of misinterpretations and misunderstandings, especially for the deaf and hard of hearing community. And so the Department of Health developed a video. Now more and more videos are being developed that are using interpreters or the use of deaf interpreters to explain the information so that the deaf community has access. And now we better understand the coronavirus. When the president gets on and he does his presidential speaks, most oftentimes there's no interpreters available. Sometimes they have closed captioning, but not all the time. It just varies from day to day. And I have seen a certified deaf interpreter working before, but it varies from day to day. It's they're delayed access to that information. It's never real time. The governor, which I really want to applaud her, she has an interpreter with her every single time she does a press conference or is on the news doing a brief. She always has a certified interpreter with her, and we're really proud of also Flint. They've been constantly for the mayor's office and with the Genesee County sheriffs. They've always been contacting and getting interpreters and making sure that the deaf community has access to the information. So we really applaud the city of Flint. And since, well, in regards to health, since the impact of the coronavirus, I work for an agency in Flint, and I would say about 90% of our assignments have been canceled that we provide service for because of the coronavirus. So it has really impacted our agency, and deaf people are not getting access. I know that Hurley Hospital, they do have full-time interpreters on staff, which is awesome. It's amazing. But other hospitals, I guess, are relying on our agency to provide service, or they used to, but I feel like they're cutting services now. And so I'm not sure what's happening. I think it's worse for deaf people because on top of that, everybody's being recommended to wear a mask. But the problem is the community, I mean, we do rely on signs, and there are those who rely on facial expression. But when you have a mask on, the person can't see the individual's lips for those who do have some lip reading ability, but also those facial cues. And so they are using a form of VRI in the hospital right now for any deaf person who's in the hospital. So they're not providing live interpreters. And that is very frustrating, not only in regards to the technical difficulties, but when people are wearing masks, there's so much of the information is missed. And so how we communicate, there's been like a disregard in regards to the way that the deaf community has had access. Our agency has been trying to provide information, doing vlogs, informative vlogs, posting those on social media, but it has been a struggle. In regards right now, I don't know how many deaf people are in the hospital. I don't know how many deaf people have died. There's so many unknowns. It's very sad. It's unfortunate that I have to wait until the coronavirus essentially goes away before I can link back up with the community to find out this information. And so I do have, there are some vlogs on Facebook of other deaf consumers or deaf people in the community who have recovered from the coronavirus, and they have put out their experiences, and wow, that was very impactful to watch their videos and the things that they had to endure while they had the coronavirus. But we also have to protect our interpreters. And so sending the interpreter into the hospital, also we send them into the doctor's offices and medical facilities and trying to provide PPE for them as the interpreter to go in. I mean, the interpreter shows up to the assignment and then they get exposed, and we don't want that to happen, but unfortunately, the deaf community really values their interpreters and they need that access, so it's kind of a catch-22. And so the community that has language deprivation, that has experienced language deprivation growing up, they struggle a little bit with reading and understanding everything that's written in English. And so they're calling me frequently here at the office and asking me, can you explain to me, what is this coronavirus? How do you get it? What does it mean? Where did it start? And I really have to expand and explain to them and basically educate them. And, you know, I was Flint raised, and many of the residents in Flint don't have technology. They don't, the older folks, they don't have social media accounts. They don't have access to that information. And then we're on stay-at-home orders on top of that. So if you don't have any technology access to gain that information, then they're really suffering. When they go into the hospital, they use a VRI, which is a video remote interpreter that's on a screen. It's like a 2D image. So they have an interpreter, but if the deaf person is too sick, or they can't see the screen, or the way that they're situated in the bed or in the room, or if they're in pain and they can't focus on a screen, like how we are right currently during this Zoom meeting, and the way that we're focusing on the screen, but if you don't feel good, then sometimes you can't see as well and you can't focus. And so then you're trying to read and understand everything through an interpreter, which can be ineffective. And then not even talking about the deaf-blind community. I mean, oh my goodness. The deaf-blind community relies mostly on tactile, which would be touch, communication access. And some don't. Some can see with like close vision. They have close vision, so if an interpreter can get closer to them, they can see. But with the social distancing, you can't touch a person, you can't get close to them, so they're really suffering. So we really need to analyze this situation, and we're just not there yet. It's new to everybody. Everybody is going through a hardship right now. And so that aside, for right now in Flint is famous for the deaf community, because we have the deaf school, Michigan School for the Deaf. And Michigan School for the Deaf just started Zoom classes with their students finally, and they're so excited that they get to set up these Zoom classes, because a lot of the students got sent home and they don't have language access at home. Many parents, unfortunately, do not sign to their children, so they cannot communicate. Some do, don't get me wrong, but many of them do not. And so this is language deprivation all over again. They're not getting that exposure that they need, and so it's a struggle. And it's even harder when you don't have language access and when you're not getting that language acquisition exposure at the school. So now in regards to social emotional, that's for the deaf community. We really rely on eye contact, facial expressions. We have video phones that we use to call others. Zooming, all of that stuff is great. It's all this technology that we have access to is awesome, but it's not the same. And I'm sure that the hearing community feels the same way. The deaf community is, we socialize, we rely heavily on social events and getting together and being touchy-feely and hugging, and how do we get access to this communication and chatting? And there's been a lot of breakdown because of all of this. They don't even understand the coronavirus. So I understand that it's a virus, but can I even go outside, or can I talk with people? And so we're trying to get the word out there. We're trying to talk with each other and support each other via social media, on video phones, whatever. But I just love conversing in sign. We are the people of the eyes. We rely on seeing others' faces and seeing the signs. And the coronavirus it has ripped all of this away from us, and it is very tough. I mean, we're enduring, and we're trying to get through it also, and we're trying to support each other. And I don't have any data to provide currently because we don't have access to any data right now. So like I said, there are a lot of places are using VRI interpreters, and so we are heavily relying on Facebook and doing blogs and trying to get the information out that way on our Facebook page. If you want to check us out at Communication Access Center for the Deaf and Hard of Hearing, on Facebook. I've been putting multiple vlogs of information out there for the deaf community so that they can kind of watch that and follow up and learn what's going on through that.
So we're going to transition now. Corey, I think you stay with me just a couple more minutes. Teresa, I hope you're going to stick around for the Q&A because we do have some questions for Teresa for the Q&A. So we'd love to hear the answers.
Okay,
and we're
sure.
going to go to our next speaker. So Corey, I am going to turn you off and turn Mitch on. If I can find Mitch here. It's not always easy finding people. So Mitch, you're about to appear and I'll see you guys later. I'm waving to you, but of course I don't have my thing on. Corey, I'm just going to turn your camera off there, and Teresa as well. So Corey, Mitch, you ready, right? Okay. Okay, so our next presenter is someone I'm very, very proud of. It's not easy to follow all these people who are really specialists in their field. And this is somebody who is just getting started out in the public health field, but she's doing a terrific job. She is one of my students, and I think she's done 2 classes with me, but nobody ever just does 2 classes with me. Her name is Tabitha Dolan, and she previously attended Alma College, where she earned her Bachelor's of Arts in Healthcare Administration. As I said, she's currently in our MPH program, and her concentration is also in Healthcare Administration. But currently, she works at McFarland Villages, which she'll tell us a little bit about as a wellness coordinator. So welcome, Tabitha. We look forward to hearing your talk.
Hi, everyone, and thank you for having me. As Dr. Sally had mentioned, I do work at McFarland Villages as a wellness coordinator. So McFarland Villages is a senior living community in Flint, Michigan that serves around 300 residents. So we do have 2 buildings. We have McFarland Home, which is an assisted living community for ladies, and it's 29 beds. And then we also have Court Street Village, which is our independent living community, and that's 256 units. So that's primarily where I'm going to be focusing on today, is our independent living residents and how COVID-19 has been impacting them and their day-to-day life. So the first area I want to talk about is just the impact that health disparities has been having on older adults, and how this isn't only putting them at greater risk for COVID-19, but also the unforeseen consequences resulting in the lack of continual care that's available. So our community primarily serves low-income older adults, and they're already facing significantly higher rates of chronic health conditions. So it's important to note that currently older adults aren't necessarily just due to their age at an increased risk of contracting COVID-19, but if they do contract it, they are seeing much worse health outcomes. So due to the shutdowns that have been taking place, a lot of our residents have expressed concern over not being able to have the same access to the primary care that they're used to having access to. For those who saw Governor Whitmer's address on April 22nd, Dr. Khaldun, who is the chief medical executive, expressed concern over Michigan residents not getting primary care or seeking out care, even in cases where it may be critical. And I think that not only are we seeing that on a statewide level, but also just within our senior living community. So we have residents that are battling cancer and dealing with diabetes and heart conditions and so many other chronic health conditions, and they're not getting that care during this time just because they're afraid of going out of their apartments and possibly contracting COVID-19 and just that increased risk of exposure. Another thing I want to talk about is in both of our assisted living and independent living buildings, we have residents who are seeing a decline in mobility and muscle function. We try our best to keep our residents as active as possible, so they're constantly going from one class to another, and they have exercise classes, always different things to keep them busy. With everyone self-quarantining in their apartments, in their units, we are seeing a lot of residents who once were able to walk short distances from point A to point B are now struggling to make those same short distances just because they're not moving as frequently. Another thing I want to talk about is just food access in low-income older adult communities. So one of the things that the media has been putting out is a recommendation that older adults should stay in their homes as much as possible, reduce risk, reduce exposure. And in order to do that and still get access to their food, they should be purchasing more groceries than they're used to buying, just to kind of reduce the amount of times that they're going to the store. And although I do think this is good advice in general, it's not always feasible for low-income populations. We did a survey passed out a survey to our residents that asked them, how are you getting to the store? If you rely on public transportation and that suddenly isn't available, do you have alternate ways to get to the store? And then also, how are you paying for the groceries once you get there? We're seeing an overwhelming number of residents express that they are using public transportation as their regular means to get to the store. And about 30% of them did say that if public transportation wasn't available, they would not have another way of accessing their groceries. With the buses being so crowded, even on a normal basis, residents are already limited in the amount of groceries that they can bring back with them. So they have set a number of bags that they can bring just to make sure there's room for all of the people plus all of their purchases. So even in cases where a resident might financially be able to purchase more groceries than they're used to buying, it doesn't always mean that there's room on the bus for it, nor does it mean that they're physically able to either carry or push that increased weight if they do buy more food. So we have been working closely with local churches and Dr. Sally in connecting residents with food resources in the community. So there's a lot of additional resources being passed out to residents within the community. One of the ones we have been working with is MI Bridges. And this is a really great resource that is offering food delivery to residents and wellness phone calls just to check in and see how they're doing for residents that are 60 years and older. And although this is a great resource and a lot of our residents have been taking advantage of it, you're only able to submit your information through an online form. As Dr. Parker had talked about, a lot of our residents don't have access to internet. I would estimate about 90% of our residents don't have internet or Wi-Fi in their apartment. A lot of them also don't have the technology where they can utilize that Wi-Fi or the tech literacy in order to run it efficiently. So what we ended up having to do to still connect residents with this resource is taking all of the question that the online form had. We then created our own paper form and passed it out to all of our residents. The residents then put all of their information in and submitted it back to the office where we were able to enter it in on their behalf. When we've discussed food access with other villages that are still within our network, one of the top responses when we talk about food access is, okay, well, why don't you sign them up with food delivery such as Shipt or curbside pickup from grocery stores? So again, I just want to reference that survey we passed out. 62% of our residents said they use either cash or EBT in order to purchase their groceries, and they don't have access to a credit or debit card, which is often needed in order to purchase from those systems. Again, in cases where they did have, some way, I know a lot of grocery stores are now accepting EBT to do curbside pickup. Often there's an increased fee with that, which they might not be able to cover. But again, it just comes down to technology access. So they don't have that technology in order to utilize those systems either. We're also being asked why residents' families aren't stepping up to kind of fill in the gaps during this time. And it's important to note, again, we're looking at a low-income population who is often experiencing cases of generational poverty, where that older adult might be the most financially stable person in their family. So we have a large rate of individuals, often their children, that are still working those essential minimum wage jobs. And whether they live further away or, due to their hours, they're just not able to step in and fill those gaps. And again, with their children still working those essential minimum wage jobs and then schools being closed, just in our building, we have seen an increased rate of residents providing childcare to their grandchildren. which is causing, you know, their day-to-day expenses to go up. It's also causing the resident to come into contact with more people, even if they do have the luxury of staying home. So whoever that parent is coming into contact with when they're working every day, they're then exposing their child when they come home, but also their older adult parent who may already be at an increased risk due to comorbidities. And then it's exposing everyone in our community as well. So lastly, I just want to talk about social isolation. As wellness coordinator, that's one of the things that I really try and focus on in my job. So I've seen a huge impact since COVID-19 and self-quarantining have taken place. Court Street has a very high sense of community. It's probably one of the top reasons that a lot of our residents choose to live there, is just it's a very social and communal type environment. So these self-quarantinings have really been hard on a lot of our residents. One of the things that we initially did to try and combat this was passing out wellness packets to all of our residents. So these wellness packets include treats. In some cases, it would include soap, notes just letting them know we're thinking about them, as well as crossword puzzles or word searches just to try and keep them occupied during this time. We do still pass those out once a week, but what we noticed, it wasn't really helping with the social isolation because it wasn't giving the resident a way to have two-way interaction. It was very one-sided. So then my family had suggested we try to do something where we could have a group phone call with all of our residents. So what we ended up doing was using the Zoom platform, and I created a daily bingo game where residents were able to call in using their home phone or their cell phone. And it was a set time and a set date. And so that was really convenient for the residents because it was using technology that they're already familiar with. And that was really key in getting them to utilize it. We had a lot of residents respond really positively to it. At the end of each bingo call, at the end of each day, one thing that we do is ask residents, you know, how are you doing? Do you have any questions about what's going on? Make sure you're reaching out to your friends, family. Sometimes we even do challenges where I'll say, okay, please call one family member, and then tomorrow when you call into bingo, let us know how they're doing. Let us know how that went, how many people you've talked to, just to try and increase the number of people that they're speaking to during this time. So we are working with a few other places in the community to try and, you know, give more resources to our residents. A common saying at McFarland is that our residents are the lucky ones. So we do everything we can to provide holistic care that focuses on their mind, body, and spirit. And all of these things that we're doing are great for the people that we serve, but it only helps the residents that are within our walls. So in order for us to see some of these things impacting positively those that are, you know, living right outside of our building, we're going to need to see a systemic change in the factors that influence the social determinants of health before we can see those positive changes. So I just wanted to thank everybody for your time and listening to kind of some of the things that our older adults are going through. If anyone is interested in getting involved, we are still looking for pen pals for our residents. So just feel free to reach out to me.
Thank you, Tabitha. As always, I'm very proud of my students. They do wonderful things and really do good presentations as well. So Tabitha was our last speaker, our last presenter, but we do have about almost 20 minutes for Q&A. So I'm going to try to go through the questions that you guys have written down. I'm going to they're kind of mixed, but I'm going to try to keep it at one presenter at a time just because it gets a little difficult switching the videos. And we're going to bid goodbye to Mitch. That was his last turn, and we'll have, thank you, Mitch, and we'll have Corey join us now. So you just give me a second. So Corey, you need to start your video. Sorry. And Mitch is, okay. And Tabitha, I'm gonna do this in the order of that the presenters went. So I'm going to start with Dr. L's questions. So I'm just going to mute your video for a minute and bring Dr. L back on. Dr. L, would you join us? Dr. L. Oh, there she is. So we did have a question for you, and it was from Dr. Amini. He wanted to know, well, he wanted to say first that stress can increase the risk of depression, which can affect the immune system. And he wanted to know if you have any research about prevalence of stress and depression among minorities during outbreaks and disasters.
I think that's a great question. And we can look back at things like 9/11. And what we know is that because of the environment, so things like anti-immigrant sentiment can raise the level of stress and distress in people's lives. In 6 months following 9/11, there was a study that found a 34% increase in low birth weights among Arab women. We also seen similar things in regards to the Flint water crisis, so that pregnancy and birth outcomes were also impacted. So unfortunately, I would speculate that we would also see these kinds of health outcomes occur following this coronavirus, but also we have to think about that when we do have a suppressed immune system from the stress, that's going to limit our ability to fight and rebound from the health assaults that come with COVID-19.
Thank you, Dr. L. Our next question is for Dr. Parker. So Dr. Parker, if you could start your video, that would be great. You have a few questions. Thank you. Dr. Parker, this question is, the first question is from Georgiana. She says her question is, how do we begin, and this is a long question, how do we begin, or what do you suggest as a way to start a conversation on addressing stigma surrounding COVID testing and diagnosis in vulnerable populations, specifically communities of color who may not be as trusting of the medical community? And then her comment is, I say this because people hear how COVID is affecting communities of color, and some may automatically think back to Tuskegee experiments. And when we talk about death and dying, some may think back to when HIV/AIDS first hit the scene, and people were thinking that if they test positive, they will die. So even if access to testing is increased, how do we get people to get tested who may have feelings of distrust or simply who may be just scared for many reasons? And so one of them, for example, primary breadwinner who cannot afford to stop working and dying, etc.
So that is a very good question, Dr. Georgiana Logan, who is a graduate of our program. So I will say this, that's where you come in, Dr. Logan, and start working on these interventions. So, but seriously, in thinking about this, I would say we would do exactly the same thing that we did when we started talking about HIV. It's going to have to come from the African-American community to start to dispel the myths, to start having the discussions about the importance of why you should get tested. You know, the reality of fear of discovery is something that is not new. We have that when we start talking about cancer diagnoses, but we have to talk about it from the perspective of, if I don't get tested, then who else am I putting at risk? And typically we're talking about those people who are the closest to us. So I think if we start to have clear messaging about why it's important to get tested, have clear messaging about what to do if you test positive and how you can socially distance yourself from your loved ones. And we've got to come up with some practical strategies that are going to work for people, and really be able to even talk about this mistrust. We're going to continuously have to discuss that and dispel a lot of reasons as to why there is this mistrust, but it has to start with our African-American communities. And I think we have to really start with those folks who are leaders in that community and having those messages come home. And I'll just say this too about, well, let me stop because I know there are other questions.
We do have other questions, yes. So our next question is from Faith, and she wants to know how structural inequities replicated in pandemic preparedness plans, and how did that impact the initial response to COVID-19?
Is that for me?
Yes.
Well, that's very funny. I don't think we had a preparedness plan. That's the issue, I think. Give it to me again. So I missed part of it. So
Okay, I'm sorry. So what she wanted to know is how are structural inequities replicated in pandemic preparedness plans, and how did that impact the initial response?
oh, how they are replicated in, okay, so I think people, I don't think they've ever really truly been addressed because we haven't addressed them when it comes to health disparities. If we had addressed these structural inequities, we would not be having the health disparities conversations that we have now. So I can say they weren't addressed. People did not think about these things because we typically do not think about those structural inequities in health in general. We in public health and some other folks who have been more aware of social determinants of health are having those conversations. But when you look at this nation as a whole, then those conversations don't always happen in those spaces and places that they need to occur. So I would say they weren't addressed and we haven't addressed them in general.
So the next question for you, Dr. Parker, is, and we don't have a lot of time, so I'm going to be trying to get through these a little quickly. Are there models out there in other urban or rural areas that have adopted strategies to address some of the issues we've discussed this afternoon, and in fact have seen improvements to improving access to care and reducing healthcare disparities for citizens in their community?
Well, sure. I'm going to talk about right here in Flint. In the early, I'd say around 2000, we had an issue with Black babies dying at a disproportionate rate compared to white babies, talking about infant mortality. This community owned that situation. They owned that health issue. And there were conversations and discussions, very hard conversations around racism and how race and racism impacted health outcomes among women in terms of their birth outcomes. So there were we had the medical community coming together. We had public health coming together. We had just folks who lived in this community coming together and having those very difficult conversations as to why racism was impacting health issues, specifically around infant mortality. So right here in our own community, we were leaders when it came to infant mortality. We saw the rate in Flint, the rate was higher than the national average. It was higher than the state average. And we saw infant mortality come down in the city of Flint. So yes, I know it can be done because we have done it in our community.
Thank you, Dr. Parker. One more question for you. So this is from Gergana, Dr. Kajabajeva, if I said it right. Sorry, Gergana, if I messed it up. Thank you for discussing the issue of essential workers not being able to socially distance at home when there are relatives with health conditions that are living together. I understand that higher mortality at home could occur when children return to school as well. How could the limited ability to socially distance at home be addressed to prevent the spread of COVID-19?
Well, that is a very good question, Dr. Kojabasheva. What I do know for sure is that we absolutely have to address this issue. Even before COVID, we know that children come home and they have lots of germs and that they can infect people in their homes. So we're going to have some real discussions about how do we teach our students, our children, about using masks properly. We're going to have those conversations about really, again, washing hands, making sure that we're sanitizing everything, understanding why it's not It's not always a good thing to hug your grandma right after coming home. So we're going to have to talk about all of those things that we need students and everybody to do to prevent ourselves from passing the virus on to our family members. But I think there are going to have to be some very clear measures that come out about social distancing within the home once we start to open up. What those are at this particular moment, I'm not exactly sure. But I do know as we talk about using masks, that's going to have to be a part of whatever we're doing.
Thank you, Dr. Parker. So I do have a lot of questions that keep coming in. Unfortunately, I'm not going to be able to get to all of them because I have like 3 pages of questions here. So we are going to move on to the next presenter who presented, the next presenter who presented to Teresa Miracle, and we'll hear from her on, I have a lot of questions for her. So let's put that on. And could you ask Teresa to turn her video on? Good, she's got her video on, good. So the first, and there's a lot of questions. So the first question is, have you been navigating placing interpreters into hospitals and other settings deemed a necessity during this time? How have you been navigating this?
So we don't really place or deem or tell the interpreters that they have to go to the appointments. When we get the requests, we send them out to the interpreters and ask if anybody is willing to go or who wants to go. I don't feel like I make that, I don't feel comfortable making that decision for them. I feel like it's a more personal decision. If the meeting can be done via Zoom or Skype or whatever at home, then sometimes more interpreters are apt to do something like that, but it's definitely a personal decision made by each interpreter.
Okay, and so the next question, so there are quite a few. Do you have any services or programs to keep in touch with each other to avoid becoming isolated? Some people may not have access to Facebook, and the same person has a second question onto that. You mentioned that social media was breaking down. What would be the best service you could recommend for somebody who is deaf?
So I would really recommend that they link themselves to the National Association for the Deaf, and they put out a video explaining the coronavirus and the information that was given by the health department. And so those types of videos that we've been posting on social media, they are accessing that information on their own personal Facebook and social media accounts. But me as a Communication Access Center, CAC, we're trying to provide more information, the more serious information, things, pertinent information that they need to have access to. And unfortunately, I mean, deaf people have been communicating through Facebook and video phones for a long time. Now, those who don't have access to that form of technology, there's unfortunately no way for us to reach out and contact them. Yeah, that's very unfortunate.
Thank you. So I have another question, which is, has there been any research done currently about the crisis, I guess, via online surveys among deaf and hard of hearing community?
No, but that is a good idea. I like that idea. I'll have to jot that down.
Okay, well, I'll contact you because I have some students who need to do some projects, so we can get that done.
Oh, great. That would be awesome.
So I still have more questions. Another question is, what could the hearing community do to assist or support the deaf and hard of hearing community through this pandemic?
I think communication, working in teams. I know that the Flint Registry for the water crisis, they've been doing a lot of communication and assistance. I think those who are isolated and living at home without access, they're the ones that need more support. but they need language access. That's the key. So that might be in the form of providing interpreting services, or if there's an agency that's willing to pay for an interpreter for various scenarios, that's a very difficult to come by. The ADA law requires access to all of this information, but for the community, but not socially. That is not written in the law. So like weddings, social events, that type of thing, it's usually done on a volunteer basis. And so that kind of makes our hands a little bit tied.
Okay, I'm just reading through the rest of the questions. I want to make sure I don't have any left. I don't want to keep jumping around. I'd like to thank Teresa so much for coming and doing this. And we still have more questions, so stay tuned. Now we're going to switch over to Tabitha, our last speaker, and I have a few questions for her before we end this. So Tabitha, if you could unmute your video, that would be great. So Tabitha, just to let you know, I have a lot of offers for volunteers within the chat, so I'll give you a copy of that.
Okay.
I know you put your stuff in there. We have, so the first question for you was, I have to find it here. Okay, first question was, have you experienced any residents at either of your facilities who have contracted COVID-19 and have recovered? And the person also says, I'm very proud of you, Dr. Maurice Davis.
Thank you, Dr. Davis, for joining us. Yes, at our independent living community, we have had 4 residents contract it. 3 of them were neighbors, and 2 of them have fully recovered, and then the other 2 are in the process of recovering. They're at the end of their self-quarantine. I will say that our assisted living building has not had any cases, so it's just our independent living at this time. We were really on top of making sure that we were prepared for it. So we started planning in March, early March, when this started coming out, and we shut down all of the activities in person, closed community rooms, and did encourage residents to stay in their units as much as possible. So I think a lot of that has helped as well.
Well, thank you so much, Tabitha. We're kind of out of time. I just want to give a few comments before we end the webinar. I will have access to, I will have a recording made of the video. So if you need access to it because you want to show it to someone else, feel free to email me. I believe my email was on the invitation. And I just want to start my video so you can see me. Thank you everyone for coming. We had great attendance. At one point we were at almost 100 people. I know it's a long panel, but our speakers were fantastic. I think they all had great things to say. I wish I could have gotten through all the questions. I probably have 10 left, but I do have the names of the people the questions were from, and I will forward those questions to the presenters that they'll ask for, and hopefully they'll be able to answer those questions maybe through an email or something. Also, before I go, I just want to say that this virtual panel was pretty last minute, and it really grew out of the last virtual panel that we had. People sent me ideas, and one of them, a lot of them, said they wanted to hear about vulnerable populations, and I think we got together a great group of people here to speak about that. So I'd like to say thank you to all of them, and thank you to the interpreters who really put up with me and Sandy Campbell nagging them all week, making sure that we were going to be able to make this happen. And thank you to the guy at Zoom who's not here, who actually showed me how to do it. Again, email me if you have any ideas for other panels. I fully intend to do them again if there's enough interest in those panels. So that I will say goodnight to everybody and have a great weekend, I think. No, it's not weekend, it's Tuesday. I'm sorry. It's been a long week for me, but stay safe, stay home, be well. Bye.